session today. Let's move on. So let's start off with our territorial acknowledgements. So today we have the privilege of coming together on unceded Musqueam, Squamish, Tsleil-Waututh territories. May we recognize this honor and approach our work with honesty, compassion, and understanding. Just to go through today's agenda items, we'll do a quick introduction. We'll be focusing a lot on the system today and to validate all the outstanding build we have done for the doctor's clinic and any review any outstanding workflow questions or gaps we may have. And then we'll finish off with some questions. And just a note that this session will be recorded. It's just for us to look back for note-taking purposes. Is everyone okay with that? Okay. I'll take silence as okay. So for introductions, I just want to confirm that we have all the SMEs on the line. I think I do see Dr. Song. I see Daniela joining us. I think this is your first time on the call with us. Welcome. And then is Kathleen and Heidi here by any chance? Not sure if you're on mute, if you're here. Maybe I do see a heme reception. That might be her, I'm assuming.
That's usually Heidi. I just don't see that. I think they can see us, but I don't know if they can hear us. Heme reception, if you can type in the chat, that'd be great.
I think they might not have the sound. No audio.
I can type in the chat.
Thank you. Okay, I will move on for now. Thank you, Haley and Anna. Oh, okay, Kathleen is sick today. Okay, thank you, Haley, for explaining that. So we do have quite a few members on the CSE team, and that's on the call today. I won't go over everyone's name, but if you are speaking, please make sure to state your name. Okay, Daniela, sorry, I can't get my speaker to work. Okay. I think while we get that sorted out, I'll go on we'll just get into the high-level overview of the end-to-end clinic workflow again. Just for a quick refresher, and for all the SMEs on the line, if you have any questions, feel free to stop me at any time in between. Be happy to answer any questions. Okay. So we'll start off with the external workflow referral process. If you do receive any external referral, I know this is not as common as your internal referrals. You will be receiving a fax, and that goes into your work queue monitor. It's an electronic application that converts your paper forms into online or electronic version. So the clerk will receive the electronic referral, which will most likely be Heidi. She'll double check with the referrals whether it's an urgent referral or just a regular referral, and then she'll create the referral encounter and set the referral to triage status. That is when Dr. Song comes in. You'll take a look at the referral management page. You'll review the patients and that referral, making sure you have everything you need to make a decision whether you want to accept, reject, or you request for additional information for this patient. And then once you have placed the order for that, it'll go back into the clerk's queue. And at that point, the patient will be scheduled for the appointment, and then any chart prep will happen at that point as well. For the day of the clinic visit, the clerk will check the patient in, most likely Kathleen. Daniela may be completing any nursing assessment, any nursing notes, and then Dr. Sloan will take over for any provider pieces as well, provider assessment, documentation, placing any orders for labs or any power plants that will happen at that point. As for the internal referral piece, that is for anyone that is on the CST system. So all they have to do is place a referral order that will quickly check with you to see if the naming and the information is correct. We did make some updates from last time. So they'll place a referral order in Cerner, and basically the same triaging process will happen. Any questions before we move on? And then let's see. Do we have Daniela on? Can you hear us better now?
I'm Heidi from Henrietta's section. I'm on the phone as well. My audio is not working.
Oh, awesome. Thank you, Heidi.
Yeah, so but I have the screen going, but I have the phone on.
That's great. Thank you. Thank you so much. Okay, I see another phone line. These phone lines, and I believe that might be Daniela that just joined us. Okay, great. So let's move on. We'll get into the system. We'll be doing our external referral first, me and Pam, and then we'll go into our internal referral piece to show you guys.
Thank you, Agnes. Good morning, everybody. I'm Pamela from the scheduling team, BA from scheduling team. So I'll be doing the demo for the external referral. Please give me sharing access to share my screen, Agnes.
I believe you are a co-host now. You're able to share your screen. Perfect.
Okay.
Your screen has come up. Thank you.
So as a clerk, I would, so for today's demo, we'll be using BGH asthma. In the case of the doctor's clinic, it will be VGH BMT doc. HIM is still in the process of completing the queues for VGH clinic. So for today's demo, we'll be using BGH asthma. And as a clerk, I would receive a new referral and I would double click to go through all the details and ensure that everything is correct. Then I would go here to select the patient. For this demo, we'll be using CST PET demo to attach the patient to this referral. So I will search for my patient. So I've seen my patient, then I will go here to create an encounter by clicking add encounter. Then here I would select VGH bone marrow transplant as a facility. Transplant doctor's clinic. Click OK. So now MPI search is going to be done. Then a referral management conversation dialog box opens. And here I will go to encounter information. For the medical service, I would select bone marrow transplant. Reason for visit, I would indicate new referral. And my referral provider, I'll put the referral provider's name. Here I'm going to select Jacqueline Michelle, and I will indicate here that is an external referral. Before completing, I will go to the referral info tab, and referral received date is today, so I would just hit on letter T to indicate today's date. And for referral status, I would select ready for triage and hit complete. No, I'll hit OK. And an encounter number has been generated for the external referral. Before Agnes continues, I would complete the process by indexing the patient chart. Here, I would select referral package. I hit OK. Then I would select for the status, because we've completed attaching it to the patients, then I would select complete here. Then I would go over to performing provider. This is just a way to communicate with the provider that it's an external referral, and I would put scanned and scan document, and I will click OK. Then this has fallen off the queue, and Agnes will complete by accepting the triage. So Agnes, over to you. I'll stop sharing my screen. And after then, Jacob will go ahead to monitor the PM office and complete scheduling the appointment. Thank you, Agnes.
Thank you so much, Pam. Okay, so for the provider to triage, we'll go to the referral management page. You just need to select a location, just do a search for a location. You just need to set this up once. So we have the bone marrow transplant doctor's clinic. We select the referral triage status to ready for triage. That's what Pam had earlier for the patient, since the patient's ready for a triage. And then we'll just run this report. What happens is it will pull up all the patients that's ready for triage. And then there's other columns that have more information as well. One column that might be useful for you guys and that the clerk can set would be the triaging priority. So they can set it, I guess, 1, 2, 3, depending on how urgent the case is. So that might be a useful field for you guys to use.
You guys have a standardization of what the triage categories are that's used across all of Cerner? Or is that something we have to make ourselves?
The referral status, is that right, Dr. Song? This one?
No, the triaging priority, the column that you had just talked about.
This one, I think there's a standard set of numbers to use.
Okay, I guess, yeah. So, and does it have a legend, or do we know? Because like one could, depending upon the grading, one is either high or low, and 5 is either high or low. Do you know what I mean? Is it like 1, 2, 3, 4, 5, or is it high priority, low priority, intermediate priority, that kind of stuff? I guess can you actually demonstrate how you would prioritize it to me?
Yes. Can I grab Jacob or Pam on the line to show that field for?
Yeah, we can actually. We're going to go through our internal referral process, and we can demonstrate it there.
Okay, thank you.
Yep,
Yeah,
and
good
so they
afternoon.
just do have 1 through 5. However, every clinic can use it differently. So there's no standard across the board. So it's kind of just clinic standard practice.
Okay, because I guess, I'm just thinking, but that might get confusing. One clinic might have 5 as high priority and the other clinic might have 1 as high priority.
Mhm.
This is, I guess, but I guess this is what I guess we'll all figure out.
Mhm. Oh, thank you for bringing that up, Dr. Song. Okay, so for our patient, test patient, we're using the CST PET demo. We'll click this patient the first time you see this patient. This assign relationship window will pop up. So we're the triaging provider today. That's what we'll select. Perfect. We'll get into the patient's chart. To view the referral package, you'll just have to go into the document section and you can open it up. To view this document, we'll see the PDF pop up in a quick moment. That was a PDF that Pam attached earlier. You'll just review it. If it's an internal referral, most likely the notes will be, the consult note will already be here, but for external, it probably will be on the referral package. Any internal or external labs will show up below in these lab section. So you can, and diagnostics as well. So I think those were the main things that you do review for the patient. Okay, so after we've decided whether we want to accept or reject this patient, you just go to the quick orders page. There's referral components. Referral components where you can accept or reject these referrals. Just use the VGH component. So we're accepting this patient. We'll just place this order, go into that green box, and then if you want to add any details to your clerk, then we'll go into this order and let them know when you want to, what the scheduling priority is. So I'll just do next available appointment. If you have any special instructions, to let Heidi or Kathleen know, then you put it in this box for this instance. If you know the visit modality, then you'll also enter it here as well. Okay, so we'll go ahead and sign this order. And once that's signed, it'll fall into the clerk's queue, and then Jacob will pull up PM office for us.
Can everyone see my screen?
Yep.
Perfect. So now that Agnes did go ahead as a triaging provider and place that accept referral. So before Agnes placed the accept referral, this CST PET demo referral status was ready for triage, but right when that order was placed, it is now accepted. Our scheduling priority updated to whatever the triaging provider inputted, and any special instructions will flow over for the clerk as well. So for the external referral process, there's going to be no request in the system. So standard practice will be having PM office open on one screen and chat book open on the other. So the clerk will have chat book open. Let me delete this. So we'll enter our patient's name, and then we will click on our referral encounter and select OK. Then we can go through and select our appointment type. So if this is leukemia new appointment type, our location's at BMT doctors. If we wanted to schedule to a specific doctor, we could go here and schedule to Dr. Song. If we decided Dr. Song is in room 693 today, we could go ahead and select a room. If we weren't scheduling to a room, we could uncheck this box. But let's say we're in 693. We can enter our reason for visit. Our referring provider, we will copy this over from PM office. Our referral receive date, again, type in T for today, copy over our priority from PM office. So this was next available appointment. Enter our interpreter required, and then our visit modality. If this is going to be Zoom, a phone appointment, or in person. And then we have our our scheduling comments here. So if anything we want to communicate to the provider, this will show face up on Ambulatory Organizer. So we can type whatever we want, and then we can click move. So here we can, since we pulled up Dr. Song, it's only going to give us Dr. Song as an option to schedule to. So we can drag and drop to any time we want. So let's say noon is a perfect time. It's going to book to our provider, and it's also going to book off our room at 12. So this room can't get double booked, and then it's going to book our patient as well. So we can go ahead and confirm. And then we make sure our confirmation looks all good, and we can click OK. So now the patient is all checked in. We can look at our bookshelf and make sure under Dr. Song that our patient is scheduled for today. So I'll flip it back over to Agnes. Just want to make sure there's no questions or anything else anyone else would like to see, but we're going to go through the internal referral process, and I will go through the whole check-in process as well.
Okay, let me just take the screen back. Just wait a few moments. Okay, so in terms of the internal referral process, so I will pull up a different patient. Okay, so say we have CSE PET Demo 1 as the patient, and we wanted to refer to VGH BMT's doctor's clinic. So we'll just have to find the referral to there we go. We have a decision point right here. Last time we did want to add the reference text, so we just want to quickly review this piece with you guys and make sure all the information that we wanted to include on this reference text is there. So this text comes up whenever another user within the Cerner system would like to refer to doctor's clinic, and this outlines what they need to include or what not to include. I think we did add for the urgent referral, if the patient does need to directly admit to inpatient ward, they would just contact the physician on call directly so it doesn't go to doctor's clinic. And that the user would also need to complete a referral auto text, which is a note. So Dr. Song, do you mind quickly reviewing this to see if you have anything else or we're good to go for this piece?
I think overall, I mean, like this is what I wrote, but so yeah, that should be fine.
That looks good. Okay, perfect. Thank you. So go ahead and do the order. And last time we also did make a modification to the naming of it. We want to update it to outpatient VGH BMT doctor's clinic and new patients only. And this is okay?
It looks fine to me. Agnes,
Yes.
I was just thinking, and I've struggled with this phrasing as well too. Could you go back to that page where we have the who we take care of?
The reference text or
the reference text, yeah.
Okay, yeah.
I just thought that maybe I should actually get rid of one sentence. I've struggled with this issue because it's a difficult one. But in the exclusion criteria, could you remove exclusion criteria, the second line, patients who are not eligible for MSP coverage? Just I guess remove that. I put that in, but I've been having some thoughts about it. It's just that there's nuances which I won't go into, but just get rid of it. That should be fine. Yeah.
Okay, perfect. We will remove that and then we can send you a screenshot post session to quickly validate with you. Thank you. Okay. So for the order, I'll just have to complete it in order to fall into Jacob's queue. So scheduling priority depending on when you schedule in to let the clerk know. The location will be VGH BMT doctors. Visit modality is not required, but if you do know, and then the reason for the referral. Okay. We will go ahead and sign this order. I will also go into our auto text to quickly take a look to see if there's anything else we need to update or we're good to go. So I'm just going to open a free text note for that referral. And then we have VGH BMT new patient. We have to drop down the yes and pending. They're all defaulted to a blank. Dr. Song, was there anything you wanted to update for this referral auto text, or we are good to go for this one as well?
Just having a quick read of it just to make sense.
No problem. Take your time.
Maybe just to clarify a couple of things. So in multiple myeloma skeletal survey, could we change that skeletal survey or other imaging? Skeletal survey, comma, other imaging?
Sure.
Just add on a little bit.
This is okay?
Yeah, that's good enough because there's many different types of imaging you can do for this. And here, when the next line, it's serum protein electrophoresis. That's part of the same word, right? Or same, because the way it's on the next line, it just makes it seem like, yeah, perfect. Could we right after that, could we put, after serum protein electrophoresis, could we put serum free light chain levels?
On the same line?
Yeah, serum free light chain, L-I-G-H-T, light, L-I-G-H-T. Levels, yeah. L-E-V-E-L-S. Okay. That sounds good.
Yes, I will cap these as well. Good align with the other ones. Levels.
Okay. It all looks good otherwise. I think it's fine. Yeah. Thanks.
Okay, awesome. I'll quickly take a screenshot just in case. Okay, got it. Perfect. So the referring provider will complete this and sign it. Why don't we just sign it? And so it's saved into the chart. Okay. And then once the referring provider places the order, it will go into Heidi's queue. So Jacob will pull the demo out, and then he'll also demo the triaging priority piece that we mentioned earlier.
Perfect. Let me know when everyone can see my screen.
Yeah.
Perfect. Okay, so as a clerk, any internal referrals or follow-up orders are going to fall into our scheduling queue. So to navigate to our scheduling queue, we have our eyeball icon up here, the appointment inquiry. We'll toggle over to our request list. And for our BMT, we are using the queue of AM BMT future request, and our location is BMT doctors. So we can click find. Any follow-up orders or referrals will fall onto this. So Agnes did place that referral to order, so it is going to fall on our queue. So let's imagine that this referral does need to be triaged. So to get it to triage, we will right-click, click on Modify. Once we click on modify, we will click on set encounter, add encounter, and we will use our referral management encounter. We'll type in our VGH bone marrow transplant doctor's clinic. So again, this is just us creating our referral encounter. So we're going to enter our medical service, enter our referring provider, which we can see on the request list. And then we can navigate over to our referral info, enter our referral receive date, our referral status as ready for triage. And here's where we can select our triaging priority. So again, here's the different options that we have. We have 1 through 5 and then A through J. So depending how Doctor's Clinic wants to use these numbers, if it is triaging priority, standard across the sites have been 1 is the highest priority, 5 is low, and then A through J, that just depends per clinic if you would want to utilize these. I don't see this very commonly, but if we do want to utilize the triaging priority, we could have 1 be severe and 5 the least severe. So we can just go ahead and select 1 if this is a severe case and then click complete. That creates a referral encounter for our patient. And we can select OK. And then we have to enter it one more time. And then hit OK. So just to show on PM Office, since we did just create a new referral encounter, it is going to be here set as our referral status as we're ready for triage. Again, once we do schedule these appointments and flip the encounter to pre-outpatient, it will fall off this list. So let's go back to our request. So it is ready for triage. Let's imagine Agnes goes through a triaging provider and does place that new accept order. So it'll be that same exact workflow. We'll assume on PM Office this did update to accepted. So we see it's accepted and we can go and schedule it. So what we're going to do for our request is right click and complete our request. It's going to have our order here and we'll select OK, and it's going to pull our patient into our work in progress or our WIP. From here we can go either drag and drop, or we can go over here, select our doctor. If it's going to be Dr. Song again, let's say Dr. Song is in room 689 this time, and we can hit move. So it's going to bring up just Dr. Song, and we can go ahead and schedule for 1 o'clock. It's going to schedule, again, Dr. Song, room 689, and the patient, and we can go ahead and confirm. So once it is time to check in a patient, we will have our book open. When the patient does arrive, we can, actually I did miss this up. So once the patient is scheduled, we will go over, we'll have PM Office open on our other screen. So this is accepted and scheduled. We will right click on the patient and pre-register outpatient. So our encounter strategy, so once a patient gets referred, we'll create our referral encounter, which forces the patient onto this list. And then once the patient actually has a scheduled appointment, that's when we flip to a pre-outpatient. And then once the patient checks in, it will be a register outpatient encounter. So our encounter type will be pre-outpatient. It's going to flow in all the information that we had from our referral encounter. So really all for pre-outpatient, we just go ahead and flip it and complete. So again, it just keeps this list nice and organized. Once it's scheduled, it's going to fall off this list because it's not going through our triage status anymore. So once we get to the the patient being ready to be checked in, we can, let me refresh this. We will right click on our patient's appointment, go to actions and check in. There's a few other ways to check in. There's an icon up here for check in, but I like the actions check in. And then we'll select OK. And then we will use our register outpatient conversation. So once we have the patient in front of us or on the phone if it's a virtual appointment, we are going to want to make sure we have all the correct demographic information. We're going to select an outpatient encounter type, their source of ID, their PCP verified, and then we'll go through and make sure their insurance is correct. And then we can go ahead, is this an accident-related visit? And then we can go ahead and complete. So then we have the patient all checked in, and we will see the status flips to green, and this will let the provider know on ambulatory organizer that the patient is checked in and waiting. Any questions with that workflow? I'll take silence as no. Perfect. So passing it back over to you, Agnes.
Thank you so much. Just share my screen again. So there's just one more piece we want to touch base on in regards to the triaging and referrals. There is a sub-workflow that we identified, which is the urgent referrals piece for this clinic. We do know and we just want to double, I guess, confirm the workflow for you guys, since last time we just had a few questions, and then just making sure everything's okay. For triaging urgent referrals, what I have up on the screen is the external referral process for these urgent referrals. We do know that these cases might be rare, but we do have the workflow identified for you just in case. So in the case that we do receive an external referral and it is urgent, we will receive it through Working Monitor. Heidi determines whether it's an urgent referral that requires the attention from the inpatient provider or not. So if it does require the attention from the attending provider, then she will make an out-of-system communication, whether it be phone or pager, to go back to the clinic clerk that will make a note for the referral request. And then at that point, if the attending provider does think it's necessary for them to be admitted to inpatient, then they will follow the inpatient admit workflow. Just one thing to note, though, that the patient will need to be discharged from the referral encounter under doctor's clinic before they move into the inpatient side and inpatient BMT. The other option is if they don't require urgent referral, then it goes back into our regular referral triage process where we showed earlier with Pam. And then the only thing that Heidi will add into the notes for the provider to see, which may be Dr. Song, is that this referral has been reviewed by the inpatient provider already. Any questions for this part from the clinic's piece?
So when the referral is initially created, so back I guess at the turquoise diamond there, will Heidi at that point, irrespective of where this person is triaged to, will Heidi be registering this person on Cerner? I guess what I'm asking is that if she gets something, you showed us way at the beginning how she registers this person into Cerner when she receives a fax, for instance, right?
Yeah.
Do you remember that? where you showed us right away at the beginning of this session, you showed us how she registers the person. So she's got to register every single person irrespective of which pathway it goes to, right?
Correct.
Okay, I just want to make certain that that's done just because we need to make certain that we do have a trail of the referral and that it's in the system such that we know where the information is hidden.
Yeah. And also because it will, like I mentioned, the patient will be under a referral counter under BMT's doctor's clinic first. And if it does go into, the patient does get admitted, then they'll just need to be discharged from the doctor's clinic referral counter. So yes, it will be, tracked in that case, for sure. Another piece to note that I think during the process when you accept the patient, sometimes you might need to connect with the navigators to schedule the collection date. So let me just pull up Power Chart again to show you the message sender. So you'll just use this communicate button. It's a quick pop-up basically to send a message to the navigator. So you put the receiver's name and then you'll quickly send them a message here. And then if you do need to save the message to chart, which I don't believe so because this is informal, but you can save it. These are more for full message call impromptu with patients. Okay, let me move on. So we do have another BMT navigator piece that's related to the doctor's clinic that we want to review with you guys. And I'll pass that over to Haley, which will lead this discussion. Haley, I'll have the slide up for you. I'll just speak through it. Are you on mute?
Oh, you bet. Yeah, my apologies. The double mute got me there. Thanks, Agnes, and yes, thank you for displaying this slide. We just wanted to acknowledge that the doctor's clinic is the point of contact for outpatient kind of referrals to specifically for transplant, and that we know that we are told that the candidate is usually seen in doctor's clinic, and then likely the transplant workup referral form is completed there if they are to go forward with a transplant workup, with also the understanding that patients often come into the inpatient space and then the perhaps the transplant workup referral form and the process would start there with HLAs and IDNs. Does that ring accurate for you so far?
Yeah, those are the 2 points where transplant workup referral forms are filled in and sent out. Doctor's clinic
Perfect.
And inpatient.
And we know that BC Cancer often refers to VGH, mostly for auto is our understanding, but also for allo transplant?
That's correct. They refer for both.
Okay. Is that mostly just from, and this is more of curiosity, from the Vancouver site, or is that from any BC Cancer site?
Any BC Cancer site.
Perfect. Okay. And as I said, if the candidate is appropriate for transplant, the provider will place that TWRF. And just so that you know, that TWRF form is, there's a potential for this directive to start the workup process will be completed in Cerner in future state, and that we are covering that within the scope of the navigator office design. And we just wanted to make sure that this kind of the slide is to add mention that this is an important touch point for the transplant process, especially the initiation of it. And so if there's any other considerations in regards to referrals for transplant or workflow, i.e. process with patient not appropriate for transplant and discussion at outpatient rounds, et cetera, we just wanted to leave the space open for anything that you might feel important that we might have missed in this process.
I can't think of anything specific at this moment.
Okay. Yeah, and something that I don't have on the slide, but this is also out of scope of this session, but just so you know, being covered is donor workup appointments with the long-term follow-up clinic, specifically the GPO there. Okay.
Yeah, so sorry, I missed what you were mentioning about the GPO clinic and the donor-specific workup. That's obviously a separate workflow.
Yeah, separate workflow outside, but just wanted to mention that we've got that kind of covered in another stream. So,
super,
yeah.
thank you.
So nothing else. They follow the same kind of referral process, external referral to clinic, and then the navigator process starts from there with that TWRF form and HLAs and IDMs that requisition being provided to the recipient in clinic.
Yes.
Perfect. I think that's about it.
Sorry, that last little bit about the requisitions being supplied to the patients, the lab requisitions. We sometimes do supply it to the patients in the clinics. Sometimes we leave it for the navigators to communicate with the patients and then to sort that out for a variety of reasons. So it could be one of two things, yeah. Because you're referring to blood tests for HLA typing and that, right?
Yeah, it's kind of an initial startup for the recipient workup.
Yeah, so I might see a patient and I might give him the requisition for HLA typing blood tests, or I might just send them off without this, and then the navigators may arrange that, a part of it. And I don't know whether, so obviously there's variations on a theme, but if someone lives locally or if they are staying overnight, then they'll be okay with going to our lab here. Sometimes people are trying to catch a plane back really quickly to where they live and they won't get the blood test done here, and then I leave it to the navigator to sort that out then.
Fair, that makes sense. But always that TWRs completed at that time.
Yeah, TWRs are completed either right after you see the patient, or sometimes we end up doing it a day or two afterwards in our office or whatnot.
Right. Okay. I think that should be fine. Anyone from my team have any questions in regards to transplant process that starts within the doctor's clinic? Perfect. Thank you so much.
Thank you. Okay, so at this point, we will move into the nursing assessment, documentation assessment demo. I will pass that on to Erin, who will be leading that.
Hello, everyone. I'm Erin. Just let me know if you're able to see my screen. And can you hear me well?
Yes to both. We can see and hear you.
Excellent. Thank you. So I'm just going to go through some really quick steps as to what the nursing staff would be doing on the day of the patient's visit to your clinic. We understand that there are nurses involved with getting patients prepped for their visits, and just jumping right in here, I'm signed in currently as an oncology ambulatory nurse. And you can see that this patient has been checked in previously by Jacob. And I'm just going to navigate into this patient's chart. Actually, prior to doing that, this is where we would have, as the nurse, we would set up our resources for the day so that we could see either just Dr. Song's list or all of the doctor's clinic lists or specific list of patients booked to nursing. So I'm just going to log into this patient's chart. It asks me to assign my relationship, so I am the patient's nurse today. And this just opens up into our workflow summary pages here, which of course everyone will get more training on as they go through the specific workflow reviews and boot camps. But just a quick look at these tabs each have various information within them and various documentation capabilities. So this tab here, we can see all of the documents that are already available on this patient. We could document the patient's allergies here through this view. We can also look at if any medications were given. We can look at the MAR over here in this tab. This patient has had no medications, but if that were relevant, we could look at that. Because this is a new patient, they would be getting their PRISM form on paper to complete. If it was a follow-up patient, they would be getting their problems since last visit also on paper still. Those forms would be completed by the patient and provided to the provider for the appointment and then scanned back into the chart, and they would be available here within documentation in that patient's chart after the fact. Just some quick things here. As the nurse, we could, if it's relevant, we could document vital signs. Again, medications if they were ordered or we were giving medications. We can do medication review. But here today, I'm actually just going to quickly document some height and weight. And just a question here to the group. Do you double sign the height and weights that are documented in your clinic?
So this is a tricky question. Okay. What I would say is that, you know, if I'm seeing someone at doctor's clinic, normally, and Daniela, I think you're on the line. I presume you're the Daniela in doctor's clinic?
Yes, I am.
Okay, sorry, Daniela. I just had to verify because there are other Danielas that are in the program. So they would get typically a weight, not the height, but we could keep it there. And it's just single. And it's just for us to allow us to trend over time type of thing. Now, when we have to write chemo, then they have to get a double height and weight. And
double signed, yeah.
Yeah, double signed. And so I think that from previous sessions, we have a functionality for double signed height and weight for chemotherapy writing. Is that correct?
So we have this within this view here is where the nursing staff would do their double sign. So if they were double signing just the weight, they would do that. If they're doing both, they would select that.
Okay.
And then upon signing, it gives the opportunity for the second nurse to also enter their signature.
Okay. And Daniela, are your height and weights allowed to be one of the two signatures, just out of curiosity?
Yes. Yeah, and currently we've actually been just taking them to daycare and putting them in the chart. But I guess in future we'll put them here.
Yeah, I guess in the future, if I see someone in doctor's clinic and I need a double height and weight to write chemotherapy, then you or Colleen would do it, and then you would take the person over to the daycare side, and then they would do it, and then they would just sign it in their Cerner chart, I guess.
Right, okay.
Okay.
Yeah. And you'll see here when I sign, so this is the opportunity for the second nurse to enter their signature. So we're just going to quickly pull up a second nurse name. And of course, in real life, the two nurses would be side by side just for efficiency's sake and would go ahead and do their co-signing together. I'm just going to select a nurse practitioner for this case. And this is where now the witness is going to do the sign. Oh, of course, I chose a disabled account. Pardon me. You get the idea, though. The second person's, the witness signature opportunity would come up here, and they would go ahead and sign. I'm just going to cancel this for ease of continuing with the presentation. Yeah, and like I said, if there were vital signs that needed to be documented, they would be documented here as well. I don't know if you do ESAS at all or NCI grading, but these are all available here. If there was anything additional that needed to be documented, there are different ways of accessing nursing documentation. But generally speaking, we would go through this workflow tab here, and we have the option to create a nursing narrative note. There also may be different power forms that could be documented on within this clinic, and those would be found by going through the ad hoc folder here and finding the appropriate power form that needs to be documented upon. Once I have finished as the nurse with this patient, I'm going to navigate back to Ambulatory Organizer, and I'm going to update this to Seen by Nurse to indicate to the rest of the team that the nursing assessment is complete. Are there any questions about nursing assessment in the clinic? All right, great. Thank you. I'm going to hand it back over to Agnes to continue the presentation.
While we have this quick pause, Agnes, could I just ask you a question that I guess has been at the back of my mind, but I keep on forgetting to raise?
Yes, no problem.
I think that in previous sessions after that, you guys sent me some homework, and the part of the homework that I keep on forgetting to do is the part about the quick orders and that kind of stuff. I guess I'm just a little bit lost in that thing, so I just was wondering whether I'm not certain we'll ever have time for this, but I probably might need someone to walk me through exactly what the capabilities and availabilities are, because it seems that there are some quick order labs that come from other groups that do hematology, and I guess I'm just trying to figure out as to whether what you're wanting from me is routine lab sets that we send for patients, because a lot of these are like inaccurate as orders. For lab tests that we send out to patients, or whether it means more than that. And I think even the ones we have in ACRO could probably streamlined in some ways. So I'm not certain that we need exactly what we have there, but and also, of course, we may just have just take a hematology lab rec that has basic stuff, and we just might just adjust it slightly for other ones that are post-transplants or not. I mean, our labs are not necessarily the most complicated. They just have some slight variations, is the way we put it.
That's fair. So what I'll focus on in a moment when I do the provider workflow, I'll review the quick orders page, and we'll spend a little bit more time there. And then if we do have time at the end, it seems like we're pretty good on time. So if you have extra time for the session that we booked today, maybe we can spend that time to collect the requirements from you after you've I guess, have a better understanding of how the quick orders page work. But we will have an ACRO discussion today. It's we do have it on the agenda near the end. So I guess we can go ahead and do the provider workflow. And then when the quick orders piece come up, definitely you can let us know what other questions you have there as well.
Okay.
Okay. So I am on the ambulatory organizer. So for the clinic, day of the clinic visit, Dr. Song, you as well will be on this page to see what patients you have to see for the day. So we have it on April 22nd for the VGH BMT Doctors Resource Group. We see that this patient has turned green, indicating that it has been seen by a nurse. I'll just refresh in case there was any other updates. Okay, great. The location, this can be also selected. It has been configured for you guys. So if the patient's already in a room, that's an indication of where they are. It's just a visual piece for you to see. We'll go ahead and click into the patient. It's a first time accessing this patient as a consulting provider. So we'll go ahead and click that. The patient's chart will pull up. I think last time we did a quick demo, all the key demographic information for the patient will appear at the top. You can see the location and the encounter type on the top right corner, and any allergies on the top left. We'll be mainly working on the outpatient chart. This is the workflow tab that will, I guess, help you and guide you to your provider documentation. There were a few components or headings that Aaron went through earlier that is quite useful for us. For example, the documentation. You can review any documentation completed by other users, or you can filter it to yourself as well. My apologies, I just select that up. So you can, or also just filter to nursing and allied documentation if there's something you want to reference for that. So these are very helpful filters for you. You can sort of for the last 24 hours, 3 days, 7 days, group by encounter, which might be easier to do as well. So you can just play around with it once you get access to the domain. Okay, you'll be able to view the patient's history. You can add diagnoses as well here. Any headings that have the extra hyperlink, if you click into it, it brings you to a separate page with more information with diagnosis for this visit, you can search it up here and change the display as if you have a different naming that you want it to view up on the top up, face up. So a lot of these you can play around with once you have access to the domain. Another important one would be the active issues. This is for adding problems to this visit. You can add it as this visit and chronic, or just chronic. If I want to choose a chronic problem for this visit, you just highlight it. Click the this visit button, and I'll click this one as well, just in case, so I can show you below how it pulls. If you can see the priority number here, when there's multiple problems that you've entered, you'll see a drop down. So if there's 2 and 3 down below, a second and third, then you'll see a 2 and 3, and then you can reorganize it according to the priority of the problems. Okay. And then I think we did go through the narrative components last time. We'll just enter in with free text. Let's see if we have any. Okay, yes, we do have vitals and signs measurement from before. So this is just a view of how it looks like if it was documented. And then for labs, if you have any labs on the patient, you can see it here. Any external labs would have an EXT at the end. That's an indicator that it's an external labs result. So you can click into it to see the trending. If you want to take a look at the other lab results, blood works, you can click into it. For these internal ones, if it's a blood work that you want to add on to your provider documentation, there's a tag button here. So you can just click tag, and what this does is it allows you to add this result to your provider documentation, and it's just a quick drag and drop instead of a copy and paste, but you can think of it as the same way.
Just a quick question about the external labs. What is considered external? And I say this because there's a lot of sites that are using Cerner now, but there's a lot of different labs. So for me, an external lab would be a lab result from St. Paul's, but the St. Paul's group, an external lab would be a lab result from VGH, for instance.
So external labs would be something like Life Labs.
So a lab result that comes from St. Paul's and VGH, if I have a patient that's getting blood tested at both places, neither of them would be considered external then. Is that what you're saying?
Those would be internal. So what we call internal, and that's including like the referrals and anything else in the system, is when it's for sites that are already on the system. So St. Paul's, Lionsgate, those are all considered internal.
There's no way in these lab results for us to know whether it's VGH, Lionsgate, or St. Paul's, is there?
That is a very good question, and let's see if it does show. I think in the orders, if you results, let's take a look at results review. Action list. Okay, yeah. So underneath results review, I clicked into one of the results that populated. And then we can see under action list, the performed by. I think this will give you more information in this section, but faced up on your workflow tab, I don't believe it will show. I'm not sure if there's anyone on the line that has more to add to this question.
And I guess similarly, external lab results, because there's many different external labs, they'll all be grouped together, right? So if someone's getting a lab from some external site, such as the Kootenays and then Vancouver Island, they'll still be the same column, right? Or the same row.
Yeah, so if you see the header here, it's just grouped by the type of labs it is in. So all the hematology external will be listed under here. Yeah, that's, yeah. So that they do come group together. You can see down here, yeah, all the chemistry, external blood work are group together here too.
Okay, thank you.
You're welcome. Okay, moving on, diagnostic. Let's see if we have any on this. Okay, we don't have any on this patient to show, but with diagnostic, you are able to view the image/report for the diagnostic results. So it connects directly. Care Connect as well, this is a single sign-on from your workflow page. So only this one is a single sign-on. There are multiple ways of accessing Care Connect. On the top tab here, there is a button, but this one is not a single sign-on if you do need to access it. Okay. And then let me just shrink this a little bit for a second. So why I did that is that sometimes with the screen resolution, this button doesn't pop up, this arrow button. And this is a very useful tool when you want to document your history of present illness or physical exam piece while reviewing the patient chart. If you need to review the patient's vitals, if you need to review the patient's history or other users' documents, then this is a very useful tool to just pop it over and just scroll down the page so that you can have both this component, this free text or narrative component while you review the patient's chart. Do passage for here. And then for physical exam, you can pop two of them on the right-hand side at the same time as well. Okay, I'll pop this back over so it's bigger for us to see. Okay, I will keep scrolling down. If we do home mech or BPMH, it is done on the home medications heading. With BPMH, let me just pull the screen up. You click the meds history button. You are able to import from PharmaNet, this import button. I can't show you right now with the testing domain, it doesn't connect, but there is this functionality to import it from PharmaNet. And then you'll just click document history. And BPMH is done at that point. Earlier, we did enter in the problems for this visit, or we selected, it will pull into your assessment and plan section. And then here you can document more information. And then with the oncology view, you will be in an oncologist, hematologist, BMT position. There is a component here or heading that will show you any ongoing oncology power plans and regimens as well. Okay, so just a lot of playing around with once you get into the system. You get to configure your own view on how you like to have it. You can drag and drop or like remove some of these that you don't need. Yeah, you can customize it. Okay, so at the very end of this page, there were hyperlinks. Aaron earlier showed the nursing version. So what we have here is this is for the oncology page, but we will have a view for the BMT providers as well. And then for the outpatient chart, we'll most likely have similar documentation. So I'll just pull up a clinic note, for example. And with the head, this is a note template. So with this note template, it auto-populates some information for you. Earlier, I put in information in the history of present illness. It populated into here. Physical exam, it populated into here. If we had any vital signs documented, it will populate as well. So there's different note templates available within the system for you. Any headings that are completely blank, you don't have to worry about. Say if we don't want diagnostic to appear on our final report and there's nothing in here, we can just leave the section and it will automatically drop off into your final report. So it will not show up on that piece, for that piece. So I'll go ahead and sign. And then at this point, if you do need to rename your note, this will follow the note template. So what the note template is, what dictates what shows up on your screen. So this was using the oncology outpatient clinic note. That's why the title is like that. If you want to rename it to doctor's clinic note, doctor's clinic note, then you can rename it here. For most of the notes that the notes that you complete, they will be distributed automatically through Accelerus and Care Connect and automatically distributed to the primary care provider and referring provider. So we don't need to add them to as the CCs or review. If you want to add anyone else as to sign this note or to review this note, you can double click or search for their name for this. So I'll just have them as CC for this one. So go ahead and sign this note and OK. So that is just one of the options of completing your provider documentation. The other option is to use a free text note. So a free text template, meaning it will pull up a blank canvas for you to freely dictate. If you use Faster, you can use your insert commands. If you create your auto text like we did with the referral, you can also pull in your auto text for that. I'll give you an example of a clinic note that Children's have configured for their site. They can pull in certain information, for example, patient information, but this will automatically pop up on your final report with the patient demographic anyway. So this is just face up for them to see when they're doing their documentation as well. We already know that we can do the drop downs, and then we can pull in information like home medications and some of the labs are specific. There's some specific labs we can pull in as well. There's a lot of information that we can pull in that you can play around as well when you get access to the system to create your own auto text. So that can be done. So I will close this for now. Any questions, Dr. Song, for provider documentation?
Not right now. I think that maybe this goes back to a question that I think we might have talked, but I might not have addressed. The issue with us having just standard templates for our consultations and our follow-up. Did you guys send me samples and I just said okay to them? Do you remember that? Our standard. You said, would this be okay for like a standard BMT consultation and follow-up template? And I don't think I had any suggestions.
Okay, perfect. So that's good.
Do you guys remember sending me that? Yeah,
yes,
I don't know.
Yes,
I don't know if you remember sending me that.
So that will be available on the BMT's page once, for go live. So we'll go ahead with the standard documentation for that. We do have another question for your notes, documentation notes. And let me just pull up the PowerPoint. Okay. This is in the ACRO system right now. And this was sent through our form repository. So we just want to, I think this is for the rounding. This is a rounding documentation for you guys. Does this look familiar at all?
Yes. This is the document that we use when we discuss patients at our transplant eligibility rounds to determine, a short note regarding their background and a group consensus about how to treat this person, particularly with respect to transplant. So this is not a clinic visit, but this is rather a note that is created from our rounds that are devoted to discussing our patients rounds.
I see. Okay. So
there's no patient encounter associated with this.
Okay, perfect. So we will add I guess this will most likely be an auto text for you guys. So I'll have a free text option on the rounding tab when you do the rounding during the inpatient visit. And then you can put in this auto text.
Yeah, this is not an inpatient visit. It's after a patient is seen and maybe seen multiple times, we have a meeting with the senior staff and we talk about the patient and we determine a treatment plan for it. So it's not rounding in terms of us walking from room to room and making notes about it. It's so it's a transplant eligibility rounds is what we call it, but we don't round on the patients, so they're supposed to specifically discussing patients in the context of transplant eligibility.
Okay, that's fair. So is this more like a group conference or like a conference note?
That's right. It's like a conference note.
Okay, perfect. That answers our question. We will have, we'll create an auto text for you for this, and we'll have it on the appropriate page with a link with a free text. So that won't be a problem. Great.
Yeah, when you do create something like this, right now we have it on an external program called SCIS, which is stem cell, I forget, something information system. And we do it on that, and then it creates a text which I guess gets scanned into our respective EMRs. But this might be a so is this going to be done through Cerner now? Is what the thought is right now?
Yes. Typically, the documentation piece, I believe it does all have to go into Cerner.
Okay. So what we would need then is, as I think you're already telling me, is that we would need a template that has these elements that you're looking at. Yeah.
What we'll do is we will prototype that for you, and then we can send that to you for review as well.
Okay.
Full session. Okay.
I mean, it's pretty straightforward. I mean, if you look at it, it's pretty simple. So hopefully that won't be too hard.
Just out of curiosity here, for other comorbid issues, is that usually done? Is it usually free text, or can it be pulled from like a power form that you document somewhere?
It could certainly be pulled in through a power form. I mean, if it's in the initial consult note, we could pull it in from the initial consult note, but we might edit it. We might find that some of them are not issues. Because we try to be very succinct. This is not meant to be a 5-page note. This is meant to be like a half-page note.
That's fair.
Type of thing. So we will have to have free text abilities for all of these sections.
Okay.
Except maybe the transplant where it says no, yes, no, present later.
Drop down. Okay.
Yeah, that one will be a drop down, but all the other ones we should be able to pull in. We should also be able to edit and do free text.
Let me cross-check to see if we have any documentations that we're creating for the BMT group for VGH that we can pull in. But yes, free text option, that will be available for sure. And then we'll have this drop down. Okay, sounds good. I think for documentation, I don't have any questions.
Agnes?
Yes.
It's Michelle. Sorry, I just have a question about this, because the other piece I don't think we've touched in is how the list that they have currently is generated. So I know the other half of this screenshot, I believe, in that system has a list of the patients they're kind of doing this conference review on. And I'm just wondering, Dr. Song, like, as well as our own team, like, have we discussed how we're solutioning that? Like how we're pulling the list of patients for this?
So I may not have totally understood your question, but the list of patients come from patients that we've seen before.
Right.
So the list would be essentially people who are already registered in Cerner.
Okay.
And so I presume that when we draw in the patient's name and demographics, anybody on Cerner, whether they're seen by us or other groups, could easily be drawn into this. Is that not fair?
Yeah, I guess like with the list I saw, or I can't remember exactly what's on that other screenshot side now, but there was some that like you had comments on that you had already done some review, or like it was a bit more interactive, and I know there might have been patient information on that side of the screenshot, so it's not on here. I just want to make sure that the team is thinking of a way that we're able to generate that list for you guys.
So when you maybe I'm misunderstanding what you're talking about list. when I'm thinking about lists, I'm thinking about sticking a patient's name to create this this note, and that patient by definition will have been registered into Cerner and into our program, because we would never create this conference note without ever seeing the patient.
Right,
But
but
sorry, Michelle, how do you track the patients that require this group conference discussion?
Well, this could be any patient that we see.
So
yeah, I guess what I'm
have
sorry.
the other screenshot. So sorry. I do have the other side of that screenshot. Did you want me to show it?
Well, I'm just wondering if that would help, because it seems like this system currently pulls some form of a list of patients for you, unless you're just saying you guys manually choose who you're doing this on. Like there is a list that's currently on the...
That's correct. So I think what happens is that, and if Heidi is listening in, when a patient is registered with us to be seen, and Heidi then plugs this person into Accuro or whatnot, and most of them will have a cancer agency chart. That is the list that feeds into this. Heidi, would you be able to, if you're listening, would you be able to comment on how things are created?
Hello. Yes, it's Heidi here. So what happens is that these are for the eligibility transplant patients.
Right, transplant eligibility patient.
Yeah, transplant eligibility ones. So what happens is that I always email you guys to provide me with the patients that you would like to discuss for that day. And then I make a list and send it to the person who's hosting the rounds.
So that's not, I don't think that's a question that's being asked. I think what you're asking is, when we populate this patient demographics and stuff like that, we start by typing in the name, and then a name comes up, and this person is then able to do it.
Oh, no, actually, it was more so a list of who you're reviewing. So I think Heidi's answer does help. It sounds, and I'm not sure if Pet needs...
Can I just show or Agnes, I don't know if you have the others. I have it pulled up. It's just because it looks like it's automated in system, so it's a good point maybe to speak to.
Yeah, go ahead. Anna, do you mind giving him?
I think I can share a screen. I just want to make sure you guys are okay with doing it for a second.
Yeah, I think, okay, good.
And I think that should do. So, can everyone see my screen right now?
We could see it.
Yeah, so it's this list that we're looking at. It looks like it's kind of pre-populated, but is this a manual list that someone has created in SCIS?
Heidi, do you have any answers to that? I think what happens, yeah, I don't think it's a manual list, but I think it's a list that's dumped in terms of the patients that we see and that's in Accuro, and then it's dumped into this other program of SCIS where it shows when the patients were seen, because this allows us to collect data regarding follow-ups and all that kind of stuff. I think that creating that list is related but separate from creating the document itself, the conference document.
Yeah. Okay.
Yeah,
I think that list is just, it looks like it's all new patients that are seen for that week that they populated.
Yeah, it's all the new patients. It's also all the old patients as well too. So I think it might have all of the list of the follow-ups as well too.
Okay.
So we don't see those things as much anymore, but obviously they're related to it, because anybody who is seen, we want to capture for a variety of reasons, but creating that document that we're talking about, I guess my point is that if this is going to be in Cerner, the patient is already registered in Cerner. You don't have to go to that previous list.
Account for your concise list that you'll be utilizing during this kind of conference or this discussion between your peers for your review. So if this isn't something that we need to make sure that we populate in system.
So your question is I think not about the conference note directly, but your question really is that list. Is that list, how is it generated, and do we need that list is what you're asking?
Yeah, I think what we've found that, I mean, through Agnes and your discussion, it sounds like this will be, this kind of template or something can be probably easily, I don't want to speak for the provider experience team, but easily replicated in system. We just want to make sure that the flow of this review session that you have is if possible, if we need to, is accounted for in system, and that you have a list to work off of, if this is what you do for this outpatient rounding review.
Yeah, so the list is not absolutely necessary for the conference note.
Okay.
And I'm not certain how often we actually use it now. It is helpful for us, but the way they've now created the more recent SCISs, I don't think that this list actually shows up. I need to check though.
Okay. So it sounds like each provider will say what patient they want to discuss.
That's it. It's not. It's. I think it's moved away from going off that list, asking people. So a part of it is, and I guess I apologize. I take it for granted that you guys don't sit in on these rounds with us. Is that when we see new patients, we pre-populate this note template that you see. So if I see a patient, because I know the patient's best, I pre-populate it. If somebody else does it, then they pre-populate it. And then we ask it to be presented, and that's when we give the name to Heidi to give to the chair of the conference.
Right. So I think that's the piece that you're providing Heidi with whom you want to review, let's say at these meetings, a list of patients, because what can be created, and Anna or Agnes, please let me know, but is similar in our ambulatory organizer, is that list of patients you've decided to review for the day. So instead of searching patient by patient, you'd be able to have a list, you know, everybody who's attending knows who's being reviewed, and could simply, whoever is documenting could click on the patient's name and open up the patient's profile. Yeah,
that's, I think that you're being pretty accurate about that, yeah.
Yeah, so it does sound similar. There's like a case conference, it's called at BC Cancer, where it sounds like quite a similar workflow, where they bring these patients and discuss them and, you know, decide what the treatment trajectory is for them. So I feel like I just wanted to make sure from a group perspective, we're understanding what happens there, so that this list and how we book it or can schedule it is understood.
Yeah, so I think that you're I might have slightly misled you, but I think you're accurate in that. And Heidi, you might be right. I think that list that was shown might be just new patients. I'm just looking at my view of SCIS, and that's the sense that I'm getting now.
Okay, yeah, that sounds. I think that sounds fair. I'm not sure if there's any other questions from provider on that one. Provider team. I just wanted to make sure we captured that.
No, I think that's a good solution. So Dr. Song, just to give you some visuals on that, it is under the patient list button at the top right here. Okay. And then once you click into it, it'll give you a view. This is just a list that was already configured. So what you can do is you can create your own list. And in that case, you would just manually add your patient to this list. And they will just appear on here. When you do create your own list, you are able to proxy the list to other users as well. You just need to make sure you manage the list, because say if you're not here, you're the only one that can be managing that list, and we don't have access to it.
So who would manage that list? Is it someone actually has to physically do it from our side, or it doesn't get done automatically?
No, someone has to physically manage it on your side, and like I guess from our discussion, you'll be manually adding the patients to this list. For that, it can filter by like certain things like encounter location, but it seems like for your case, you'll most likely have to add the patient manually.
Heidi, that's not what we're doing right now, right? It just happens. Is that correct?
Actually, I'm not sure, actually, for that one.
Because I think it happens automatically in new patients. Yeah. There's obviously, we apologize. I obviously don't know everything that goes on the back end, so it's hard for me to say.
No problem. We can definitely explore more and like learn on how to use the patient list. I know right now we only have a couple minutes to talk about it, so and it's a new tool, so we're not that familiar with it. But yeah, we can definitely like closer to go live, there will be an opportunity to explore more on this tool. Okay, let's move on. So that was the documentation piece. Let's go into our quick orders. So usually quick orders, it's separated out into inpatient quick orders, which is just called quick orders, and outpatient quick orders. There's the two differences that for inpatient and for like the medications and labs, it will, when you order them, it'll place basically the inpatient orders, labs are done at the hospital. But for outpatient, a lot of times they'll be printing out prescriptions for lab and imaging. Those most likely be requisitions. So these will be configured and set to do that. And I'll just go over a few terminologies here. So in these little boxes, we call them components, different components, or basically different sections. You'll see different folders in each section for categorization as well. So for labs, it's all already sectioned off into different types of labs as well: hematology, chemistry, microbiology, stool, urine studies, and tumor markers. And then for quick orders, a lot of times for labs, it's separated into the frequency or like the when you need to draw the blood work. So for inpatient, there's options. There's a folder for routine labs that needs to be done on a routine basis, or like labs that need to be drawn in the AM a certain time in the morning, or labs that need to be drawn stat. So it's categorized into different folders for inpatient here.
So would it be fair to say that when I look at these labs here and the labs routine, you have like every 3 days, is it a separate order for anybody who you want daily or every week or something like that? Do you have to have a separate, routine lab or what do you do? Like, I mean, I see this daily for 3 days. What if I want to make it every second day for 6 months? Do I have to create something new, or do I just auto text it, or what happens?
That's an excellent question, Dr. Song. So if we want to use part of this order, you can click into it. You can go into the green box, click modify details, and click into the order to change it. We want it for... we can just remove the 3 days, and then you can just order it as a blood work routine, and then, or you can just do it if it's just once. You can just do it for once. Then this is the once.
So every time we want to do that, we got to go through this exercise, which I guess as an individual item will take me 15 to 30 seconds to do. But if I'm doing it all the time, it just adds up to quite a bit. Yeah, at the same time, it seems quite silly to have CBC and have 5 different orders, one of them saying every single day for 5 days, another one saying every single day for 2 months, another one saying every second day for 6 months, and then another one saying every week for a year.
No, that's...
I mean, am I just being not fully aware of this capability?
That's actually, no, that's also a really good question. So this right here is your quick orders page. It's not, and you're not restricted to these orders only. These are just ad hoc orders that might be outside of your power plans that you place frequently. Any other orders that are not frequent, you can search it up, and that will appear in the search box. What you were stating earlier and what we want to get the information from you would be your most frequently ordered items. So this view is actually configured, or we met with this needs for different sites for oncology and hematologists, oncologists and hematologists, and this is what they deemed as the most frequently ordered items. So our exercise with you, Dr. Song, is to actually gather the requirements of your most frequently ordered items for the BMT group.
Well, okay, just cutting to the chase. So I could theoretically ask you for CBC and differential and have 50 different frequencies, and there would be 50 different ticks. Is that it?
Yes. But you would, generally we would recommend to put like, for those 50 frequencies, are those all commonly ordered?
Well, it's just that for us, the hematology group, blood tests are more important than anything else that we do. We do so frequent blood testing on our patients. We might do it every single day for 3 days. We might decide it for 4 days or 5 daes. And if we decide it for 5 days, then I have to go through the whole exercise you just showed me. I mean, isn't there an easy way to just have a drop-down menu of a drop-down menu of daily to every 2 days and another drop-down for the number of days? I mean, I'm just, I don't know. This
is, Kevin, this is Joanne from Order Set. So I think it might be worth Agnes thinking about an order set being developed as well that has a lot of these commonalities with the drop-downs that we can, so that providers can select the different frequencies that they need. Because I do agree that it's a lot of nuances needed for BMT, and the list here would be pretty large. So it might well be worth thinking about, Kevin, creating some kind of power plan for labs where at least everything will be in one spot, and we can't really catch every single need, but we certainly can have the most common ones that you would order in a drop-down. We can also have the order for future visit tests where you have that recurring, weekly for X amount of weeks as well. So that may be something you want to think about.
Yeah, I mean, it's like I might have a patient where I want it weekly for 2 weeks or 3 weeks, and then I might have a patient I want weekly for 6 months.
Absolutely.
But now these are like separate plans, and I might want someone for 3 months. Now, what I'll probably do is I'll be lazy, and the one that I want to do for 3 months, I'll give it for 6 months or a year, because I don't want to go through all that exercise you just showed me.
Yeah.
I'm pretty certain that this is not something that you as individuals can change, but I'm just wondering, in terms of making this a bit user-friendly, it just doesn't make sense for me to have CBC and 50 possibilities that I have to go through to figure out the one which is going to be easiest for me.
So I don't know if this is helpful, so my team can stop me, but if you are just ordering for ad hoc blood orders, you can add all the orders that you would require, CBC, light, or whatever, and then when you go in to modify them, you can highlight them all and select the frequency. But and again, I'm glad Joanne spoke up, because also if this is a frequent kind of ordering system, then perhaps an order set might be more appropriate in that. But still, you're kind of tease out. There is a way to kind of make this a more fluid process, and it can be done, and that you can multi-select them.
Yeah, I don't want to be difficult, but this will be my final point. I think Joanne understands this well, but I think order sets are also very painful. They're endless. And they constantly need revisiting. They constantly need a programmer to do it, just so I can change a queue weekly to a queue a second day.
Absolutely.
And so I really do think that if you just could choose click CBC, click frequency, click duration, that would be 3 clicks, and then you could just print it out. It's just, like a choice menu. Maybe I'm wrong in thinking like this, but maybe it's like going to McDonald's. You want your hamburger, you choose it, and then you click off a bit of pickles you don't want, and then click off a bit of onions, and then you say yes, send, and that's it. As opposed to having a separate power plan for, a hamburger with pickles, a hamburger without pickles, a hamburger without pickles and onions, that kind of stuff. But it's a system. It's not you guys, obviously, but I do, maybe it's a small point, but I think my colleagues, when they're trying to go through a busy clinic, will not have the opportunity or the versatility to click all the modifies or this and this, and for you guys to constantly be trying to contact one of us so we can have another power plan for a change of CBCs.
So I think that we see your point. And there's a couple of things that we have explored with different specialties, and we can show you. So either we have the power plan that they were talking about, and for example, respirology and pediatrics, they create one power plan, or oncology, gynecology, they create one power plan that allows them to quickly order those things that are frequently for outpatient. Now, in your case, you have different frequencies. So you want to see, instead of having one power plan for Q weekly or one power plan for Q every 2 days and so on and so forth, either we can create different boxes into your quick orders, let's say frequent labs Q weekly, frequent labs Q whatever, and then you just take those and sign them, and then they will be already set up for that. I think that could be a better solution for you. Agnes, would you be able to please look for the outpatient, I think that is respirology or ped ambulatory? It is ped resp and ambulatory, or maybe this because we are on VGH that you cannot see it.
There is ped res admission.
The admission is outpatient.
We are on ped A and B res. One of these.
There you go. The follow-up one. So just for you, Kevin, to take a look of what it could be, one of the options. And of course, this is respirology, so they have different needs for their kids. So what they did is that they create their greens titles to just kind of regroup things. In one case is for the type of test, but in another type, if we go lower, you can see they have asthma, for example. And so we can put those together, so for different tests and say just like Q4 or Q or allergen or that kind of things. That is one thing that we can explore. And the other one would be to create the specific boxes into the quick orders where we were before, in which we will just put one box that say Q weekly, I don't know, and then we put all of them will be already pre-filled with information Q weekly, but it will be one box that says Q weekly, and then another box that say Q, and that we use it for example, cancer, or for example, as well for, I think, ophthalmology, that they do have those things. What do you think?
It's, I'm sorry, I'm probably a little bit lost. As you know, when you have someone clicking buttons on a screen, it's just unless you're clicking and you're very good at it, you get lost in terms of some of it. So I have to go by what you guys think is reasonable. I guess we have all these, in Accuro, for those of you who have seen Accuro, because I think a number of you might have, we do have a section on labs. And so that's what we do and that's what we use. But the nice thing about the Accuro labs, recs that we have, is that we can actually modify it by just, pushing the backspace button and changing the frequency from weekly to every 2 weeks if we wanted to do that. I think we'll have to learn our own shortcuts as we go through this, and whether a power plan is the best way to go or whatnot. Maybe the first thing to start is by looking at the labs that we have in Accuro, and maybe those are the ones that we have to ask you to have here as a quick orders. Maybe that's just the way to go.
Okay. Would you be able? Are we able to request for you to send over the labs that a screenshot of what you have in Accuro configured for you? Dr. Song?
You know what? I really love you guys, but I have a lot of work to do. I can't, how are you guys accessing Accuro right now?
I don't think we have access to Accuro. Am I right?
We don't have access to Accuro. Otherwise, we will be able to go in and take a look of that instead of asking you. But if you let us know someone in your clinic that we can work with and gather that information, so we try to, I will look at that and try to reproduce what will be the best solution.
Heidi, are you on the call? Hello, Heidi?
We can reach out to Heidi for maybe a demo.
Yeah, I think that, I don't know how you guys have been working with us in terms of what we have or what do we have capable of in Accuro. But I think that Joanna, you have to understand that I need to let clerical people do clerical work, if you know what I mean.
Absolutely, yeah.
I need to spend my time doing, I'm speaking to both of you, Joanne Bailey and Joanne Bonilla, because Joanna, I remember you were a physician as well too, and you can't take me away from doing what I need to do, which you're already doing a lot of right now. So I can't do this clerical work.
Yeah, completely understand, Kevin. We'll reach out to Heidi and we'll figure that piece out, and we'll get some screenshots of the labs and Accuro and work from there. No problem.
I think that's one of the things that maybe you guys, I've kind of misunderstood, is that maybe you guys need to actually see what we have in Accuro, and that'll give you a bit of a sense as to some of the functionalities that we are using that are perhaps in some ways we're more comfortable with in Accuro, and maybe as we get comfortable with Cerner, we'll get a better sense of it over time. But if you could, there are, and maybe that's why a number of us will go on these calls, assuming you guys know Accuro, because you guys do talk about Accuro and how we function in Accuro in a way that seems to indicate that you have some degree of familiarity with it. But now my sense is that maybe you guys don't really understand Accuro because you haven't seen it. So it's hard for us to reference it without you actually having seen it.
Correct. So we will follow with Haley's option that get in contact with Heidi and just get a demo for us. We will be able to see what you are using and then save your time and try to explain us all this.
And she could probably send you all of our lab recs that we have that are pre-populated, which are our common ones that we use. And maybe that will give you a sense. And then if you want to, we could sit down and talk about it again as to what we can do about this.
Absolutely. Let's follow up on that.
I just want to add that, Dr. Song, just so you know, we have seen some things in Accuro, so I don't want you to think that we've been moving forward at all blindly. We just, it is important to understand and maybe more granularity, so this is a good option for us to follow up with Heidi. We do have copies of labs that are used, especially when it comes to orders to stay within the Navigator office, so we do see what can be populated in Accuro, but you're right, to see the workflow might be in more granularity might help us understand even a bit better.
Yeah, and we do have quite a few lab recs all uploaded in Accuro, so it will be easy to just print or send you guys those information.
That would be great. I don't know if my team agrees. Heidi, even to see how you click a bit through Accuro might be really helpful for us. Just so that we know how we're moving forward. So even a half hour of your time showing how to click through.
I can show you the basis, but Marilyn is actually our Accuro person. She uploads all the requisition, all that. She might be a better person than me through Accuro. She might know a little more understanding of Accuro if you want to include Marilyn Eckmeyer next time.
You're right. Okay, I do have her
She's
contact.
she is our Accuro person.
Perfect. Thank you for the suggestion.
No problem.
Okay, so for the quick orders, I guess we will have to take that back and
we will need to get back to you, Kevin. So we will look at what is in Accuro, what is the more frequent usage orders, labs, medication, and all those things, and get back to you.
Yeah, I think this quick orders, the more I think about it, is an important part to try to facilitate our ability to get through the day in terms of seeing patients. So, I think that we need to get to a point where we have a reasonable understanding on both sides as to what it can and cannot do. And I think that will be very helpful for all of us. And maybe this is why I was getting confused about some of the quick order stuff that I was being asked to do as a part of my homework.
Yes. Thank you.
Dr. Song, do you have any questions on how the quick orders work and like the limitations and functionalities of it for now?
I think I have a general sense of it, and I think that I think that on the one hand it seems very simple. On the other hand, and I don't know the design how it works, but it seems a little bit cumbersome. It's like, I think that on a design level, it would be that you had a menu and you click the 5 tests that you wanted, then you click the frequencies, and then you click the durations, and you would do that, as opposed to having 6 different CBCs with different frequencies. Then you can only choose one. It just seems a bit rigid, if you ask me.
No, that's fair. Yeah. Okay. So we'll try to get more information on what you order on ACNO first, and we can use that as a template on what to build. Essentially, for the BMT group, we're starting with a blank canvas. This is just a sample for you of what can be done. So I will move on. I do have one more question regarding to orders and power plans. So I guess from the different discussions with the BMT meetings and groups, we do know that, I think we heard that some of the medications are dispensed at BC Cancer for regimens. Is that right?
That's correct. So if I see someone at doctor's clinic, and because the inpatient is a little bit different, and what I mean by that is that if I see someone in doctor's clinic, and presumably they're going to walk out and go home after I see them, they will walk out, go to the pharmacy, pick up the drugs, and then they will go home. So in that sense, any oral drugs will be dispensed at BC Cancer, the pharmacy, the outpatient pharmacies there. Whereas if someone's inpatient, and I know we're not talking about inpatients, if they're admitted to the hospital, there are some oral chemotherapies we have to give in the hospital. And in that situation, what happens is that I think we actually stock a pile of whatever they need, and the cancer agency brings the drugs or continues to restock them. But Katie could tell you more about that. But for the doctor's clinic, yes, there are medications dispensed at BC Cancer, and these are oral regimens.
Okay, perfect. Thank you. And then were there specific ones on top of your head that you can think of, or it varies?
I think that I've been given a list of about 50 power plans. And I guess my question to you is, are you asking me about those 50 power plans, or will that be discussed in the specific power plan meetings that will be happening with my colleagues?
Okay, great. Yeah. If you have the list, and those will be discussed during those meetings.
Okay, so why don't we just leave it up there?
Yeah. And then the specific power plans, you've been given the list. Out of that 50 power plans list, I just want to confirm that there's no additional power plans that's specific for doctor's clinic that was not mentioned, and that wasn't not that anyone contacted you with for, right? We just want to make sure we don't miss anything for a doctor's clinic, that you have a specific power plan, for example, like transplant workup power plan that's specific for a doctor's clinic.
I can't think of anything. I mean, when I look at the power plans that I've been asked to distribute, one list is lists of power plan which are for chemotherapy protocols or the like. And that is obviously the cancer treatment. The second list I got was for supportive care, which are things like antibiotics or whatnot. And the third category is of meetings for CSCR meetings like this, which is, I guess, not power plans, but are workflow stuff.
Okay, perfect. That answers my question. Anyone else on the CST side that has questions for Dr. Song for this area, this topic?
Hi, it's Kate Saunders from Research and Trials. Is the list of 50 include research protocols, or is that a separate list as well?
So we are getting some communications about research protocols, and I don't know how that kind of crosses with what your mandate is. Are you guys a part of the research as well too?
Well, that's my portfolio. I'm just wondering if there was a list of protocols that are ordered within the space, if that did include also the research, or is that separate from this list?
It didn't, Kate. So that list of 50 supportive care plans was like the admissions and CM infusion of CPP products and, ambulatory plans for daycare and amongst that myriad of other things. But yeah, nothing research related.
Okay. That's all. Thank you.
So are you communicating with Wen about the research plans? I don't know if that name is familiar to you.
Yep. Yeah, we've asked her. I think she's been away for weeks and weeks and weeks. So we don't have any concept of how many protocols exist for research, nor do we have the PPOs to start doing any of that work. So I was just wondering if there was any work being done related to that from this conversation that I could jump in on, but it sounds like it's completely separate. So I'll keep trying with Wen.
I think Wen has tried to email you guys back, and I've been copied on a lot of these, and I guess I just wasn't certain how much this intersects with whatever. But there's stuff from Stefania Minutia that's been coming to me. There's a list that had come up, and I apologize because as you know, when you don't see a person and don't shake their hands and people are behind masks, you don't recognize names. So I apologize if I don't recognize your name, but there is stuff that has been sent even this week, and one said that she'd be replying to you. If you were on that email, did you send out an email today or yesterday?
I did not, but I'll look into it separately from this.
I guess what I'm getting at is that I want to make certain that we're communicating with the right people, and we've gotten communications this week. And once again, I apologize. I'm not so organized with my email, so sometimes I get confused as to the stuff that I'm getting. But if
that's okay, I'll figure it out. And I just wanted to make sure that we weren't duplicating work with two separate lists. But it sounds like I'll reach out to Wen myself today. No problem.
Okay, and you can copy me on it.
Sure.
But I know that she replied to somebody who was asking her. It went something along. Oh, here it go. There's somebody whose name is Jeanette Fezi Farivar.
I'll take care of that. Absolutely. Yeah.
Okay, so if that name's familiar to you, this email has been sent to me, to all my research people as well too, and so if you know Jeanette, maybe you can touch base with her and see where this all is, because the research part of it is critically important for us.
Okay, thanks so much.
Okay, moving on to our next topic. Just do a quick time check. We're at about 30 minutes left into the session. We just have a few more slides to go through, and then we're almost there. Okay, so going into, with this, the requisition manager and IPPDF, this is in regards to any requisitions being printed. So my first question to the clinic, Mies, is who is managing the requisitions right now? Is there someone dedicated?
Could you reframe your question? I kind of think I know what you're asking, but I don't really know what you're asking. There are recs there for radiology. There are recs there for hematology, like we just discussed. So what do you mean by who's managing our recs?
Who's managing printing, if you need to be printed, or sending any lab requisitions, imaging, diagnostic requisitions? Is there a dedicated person at the clinic who's doing all of this right now?
Not specifically. If I was to tell you my workflow, I would go to my clinic, I would sit down, I would speak to the patient, we would decide on what tests to do, I would click on the Acuro, adjust things as I had mentioned, I would print it out, I would walk to the printer, I would pick it up from the printer, and I would give it to the patient. Does that answer your question?
Yes, it does. So in this case, okay, that's perfect. Just because this might involve in the discussion with the Acuro and how we're going forward with it as well. So I'll leave this for now, but I do want to mention that at the moment, the default setting for all our requisitions, it's automatically printed. So it's essentially the same workflow as you have now, Dr. Song.
Yeah, there's one nuance to it, and maybe this might be what you're asking about.
Yeah.
For instance, like if you have to schedule a CT scan, for instance, right?
Uh-huh.
Obviously, I'm not going to just give it to the patient and tell them go and talk to the people and find us, and let them decide when you're going to get the scan. Mm-hmm. I would see the patient. I would decide if they need a scan. I would, tick the respective form. Then I would task it to my secretary, who would then see what I've tasked, and then they would fax it over to the radiology department with a priority or whatever, and then communicate with them in terms of trying to get things done sooner. So in that situation, It's one where there is a trail where the rec goes from me to my secretary, then goes to radiology. The one thing that I think maybe Cerner does differently, which I guess maybe I can get a little bit of clarity on, is that when I do it, I don't print out anything. It stays in Accuro. It gets passed to my secretary. She then faxes it through Accuro to radiology. Whereas I don't know how Cerner does that. Does the Cerner require printing and manual faxing?
That is correct.
So even for radiology?
Yes, that's any of the imaging and diagnostic orders here. They all need to be printed and faxed. So I can maybe pull up an order to show you how it looks like, and I'll give you also more information as well. Oh, yeah.
On radiology, we don't, so x-rays, we have to print it because in British Columbia, anybody can go anywhere and get that done without being in a schedule. So that is just a decision of the radiology. But anything that is like the CT scan, if you want to send the patient specifically to a location that is using CST, it will not print, but it will send it electronically directly to that site, like St. Paul's, for example. You can see that there's getting locations. You can decide where you want that patient to go, and that will not print, and that will go directly to the scheduler at St. Paul's or ABC Children's to get that patient book.
Okay, so 90% of the time, I'll see my patient, I'll want a CT scan, and if I'm on Cerner, then what I'll do is that I will sort out the rec on Cerner. I may task my secretary, or I may fax it directly to radiology, but sending it directly to radiology doesn't require me to physically print it and to fax it. Is that what I'm hearing, Joanna?
That's correct. Unless you are sending that to a site that is not out of this list. And
okay,
so in that case, yeah.
Okay, that's not hugely different. I think one of the places where we were having some questions as my understanding is that when we can actually have prescriptions on Accuro that we write on Accuro without physically printing it, and we can fax it directly to a pharmacy, but that doesn't happen in Cerner from my understanding. That for pharmacies, you actually have to print it out and then fax it physically. That's correct?
That's correct, yes.
Okay. Yeah, that's what I thought. Okay, so with radiology, it's more simplified then.
Yes, it is indeed.
Okay, thank you.
Okay, so that answers the questions for the printing options for requisitions. Okay.
So before we move from the requisitions, Kevin, your patients go for the labs mostly in the hospital, or they go to whichever lab they have a preference, like live labs or things like that?
So I would say that probably just a reasonable minority would go to our labs, but because we are a provincial program, we often give lab recs physically to our patient, and then they'll go to wherever they live, Prince George, Ladysmith, and they'll do it themselves.
Okay.
That
answered the question. We will keep it on so you can have the printout and provide it to the patient where the patient decides to come to the hospital or go wherever they want to. They will be fine. Thank you.
Thank you, Joanna. Thank you, Dr. Song. Okay. So I know we do need to get more information on what Accuro looks like for you guys and how you guys use it, but we do have a few points that we want to review for the Accuro piece that Grace will lead for this discussion.
Yeah, thanks, Agnes. Hey, everybody, it's Grace from CST Oncology team. Can you guys hear me okay?
Yes.
Yeah, perfect. Okay. So you may not know, there was a leadership decision made a while back to allow for some Accuro functionality to remain in certain clinics that would like that. So what we want to discuss and determine today is what remaining aspects of Accuro might benefit your clinic to keep within Accuro. Of course, what must stay on CST Cerner, or what has been determined to stay on CST Cerner, is documentation and orders within the VPP, so internal orders. And then what we would like to determine is what you would like or what you think would benefit to stay on Accuro, for example, external or provincial requisitions. So is there any... Yeah, sorry, Dr. Song, go ahead.
I think, a lot of this stemmed from the navigator's office is my recollection. And I apologize if my answers are not as complete as they would like to be. It would have been nice for one of you to be on the leadership call that we had, because I think this was hashed out and my colleagues had thoughts that I wasn't quick enough to think about. And a lot of this had to do with the issue of printing out and faxing and this and this. So the external requisitions, as you pointed out, are one of the major ones, because as a part of our transplant workup, we do things like pulmonary function tests, we do imaging, we do lab tests that are done in non-Cerner sites. So I think that was a big part of it, to allow the Navigator team to be able to do this without with a certain degree of ease that would allow their workflow to be efficient in the way they can. So yes, it is the external requisitions that I think were the most important part of this. So it's not just provincial labs, but it's also things like radiology, pulmonary function tests, those kind of things. Bone marrow biopsy sometimes.
Okay, so you would appreciate if that would stay on Accuro just for the ease and the efficiency?
Yeah, I think that it's going to have to be one of those things where we hopefully will have the ability to do an Accuro. My one concern, just thinking out loud and shouldn't influence anything that we do, is that we all choose a path of least resistance. And what I mean by that is that, you know, people who have some degree of availability of Accuro may begin to use it more than what ideally Cerner has initially planned for them. And so that's one of the things that sticks out in my mind. This might go back to one of Joanna's questions, and one of the things that I was a little bit, I guess, expressing earlier, is that we have these patients who have who do blood tests very far away, who are not a part of Cerner. And if I'm seeing them in my clinic, as opposed to me going through the quick orders and then trying to adjust these quick orders in a not very quick way to be daily for 7 days as opposed to 3 days, I might just do it in Accuro, for instance.
Okay. And I guess one question that comes out of that is, if the patients are within CST Cerner or not within, like a new patient coming in, how would the patient be created, or how do you see that workflow moving forward? How will they be created in Accuro if they're not already in there?
So I guess that would be something that the clerical staff would have to give some input into. I don't know if there's a way for us to, right now what we're doing is that, Heidi, I don't know if you're on the call, but I presume that we input patients into several systems at once, which include Accuro, PCIS, and CASE, because CASE is still not totally moved to a historically EMR. It's still used for BC cancer sites that are not on Cerner, from my understanding. So I would presume that what would happen is that when PCIS is deactivated or used as historically EMR, as opposed to registering people into PCIS, people would just register them into Cerner. So I guess maybe it's actually no different. It's just that as opposed to PCIS, it's now Cerner.
Makes sense.
But Accuro registration will probably not change then.
Okay. See what you're saying.
Your song, sorry, Grace, can I just ask, it's Michelle. I'm curious when you say, because in that you lumped in bone marrow biopsies. So currently, if you're sending a patient out of town for a bone marrow biopsy, how does, because that's typically not requisition based, right? Or is that through an order or?
Yeah, no, thanks for picking up on that. I might have just misspoken or just been speaking too randomly. You're right. We probably can't order bone marrow biopsies that easily outside of our own specific institution. So that may be something that we actually couldn't do. One of the things that we actually do order, and this is something that I found very odd, is that we're actually able to order transfusions in other jurisdictions. Like, for instance, we actually can order transfusions in, for instance, Surrey Memorial Hospital at their Jim Pattison outpatient clinic. I don't know why they allow us to do it, but I guess it's kind of weird, but we can intermittently do that.
do they consider, like, I guess, so you don't have ordering privileges that you know of then, or anything else?
I'm obviously not a lawyer, so I say things.
I know, yeah. I don't know.
Well, no, I don't mean this as a snark remark, but I'm not a lawyer, but I say things about what the law tells us we can and cannot do. And my understanding was that if you don't have a privileges in place, you can't order these kind of things. But we often get these responses from the Fraser Valley, like P-Search or whatnot. Oh, just fill out these forms and we'll arrange the transfusions for you. And it's like, and I just found it odd.
That would remain on paper regardless, because Fraser is not within the program. But exactly. I mean, that's always something we're asking about, privileges of other centers. But the bone marrow biopsy one I was just curious about, because usually order specific, we would say then those have to be in the system. But I would, I don't know if that's arranged.
Yeah, I would just ignore that comment. But so the Accuro we might keep for instance, on trying to arrange, for instance, transfusion for a patient of ours in Surrey, for instance. That's another place where we would keep an Accuro because it obviously couldn't reside in Cerner anyways.
Yeah, that would be on paper regardless, obviously, because they need those paper orders to carry out over at Surrey.
Yeah. So when you guys have a navigator builds, it might be helpful for you to get a clearer sense as to where they see the functionalities of Accuro being advantageous to the extent that Cerner could not accommodate it. And I think it had to do with the printing and the faxing and all that kind of stuff with all the external requisitions. And I think that was a major part of it. I'm just trying to think because I can't exactly think about other things that we were doing it for. We were also thinking about keeping it for prescriptions, for instance. There may be prescriptions that might be easier for us to fax that way. For instance, we'll get, because we see our patients longitudinally and sometimes for like a decade or more, and they're asking us for like prescriptions for hypertensive drugs and this and whatever to their local shoppers. And so a lot of us do that through Accuro as opposed to, filling out a paper copy and then getting our secretaries to fax it. For me to send a prescription for antihypertensive to a patient of mine who lives in Surrey, if I got the request now, I could probably do it in like 15 to 30 seconds. Whereas if I had to get a pad out, I had to sign it or do it on Cerner, then print it out, then go to my secretary and get them to fax it, and then they're on lunch break so it doesn't get faxed and that kind of stuff, or gets missed. And it actually, we end up having a trail of when these prescriptions were faxed. So I suspect that there may be some stuff that may have, that may reside in two places. Obviously, any power plan that has to do with, chemotherapy ideally would stay with Accuro if it's done properly. But this is where we may have some overlapping capabilities, and in a certain way, I'm worried that people will just tend towards just using Accuro as opposed to going through Cerner, because it will take us a while to learn how to use Cerner. And one of the things that I think that I'm also aware of is that, for instance, the BC Cancer Vancouver site, they still allow faxed prescriptions that are not through Power Plan.
Yeah, so the piece specifically with BC Cancer, I will say there's a ticket out there that we're discussing how that workflow can work. We just had word back from the pharmacy college that the electronic signature is acceptable. So there's just some work being done, and there's like a ticket going forward before we can really answer how the prescriptions filled at BC Cancer will work, but it may not need to be printed and faxed between those two facilities. It was just we needed some clarity from the pharmacy college.
Oh, okay. So that might make it easier overall. Just to round out that issue, my understanding is that a part of the reason why they still allow the faxing scripts to come is because there's a lot of non-Cerner site/physicians who work in places like Burnaby who may fax prescriptions to them as well too.
Yeah, there's the outpatient pharmacy doesn't totally use Cerner, so absolutely there's some a mixed approach there.
Yeah.
Okay. So just to wrap that piece up, external requisitions will be helpful to remain in Accuro. We're a little interested to see how when we do go live with CST Cerner, how the line might blur a little bit with Acuro and CST, just because providers and all the other clinicians are getting used to the functionality of CST.
Yeah. I guess my ultimate hope is that CST will evolve in a more user-friendly way as we begin to understand what more user-friendly really means.
Yes.
And as we begin to, as it evolves, over time, my hope is that Acuro will become redundant, but I think that we need to make CST nimble over time such that Acuro does become redundant. But I think when we had discussed this at the other meeting, really that was kind of the thought, is that maybe Acuro having both will bridge us to a certain point such that we because there's so many places of vulnerability for our program as we move over to Cerner that we're trying to mitigate this, and this is one of the mitigation measures. But once we are fully entrenched in Cerner, hopefully we'll find out that there will be efficiencies that you can create or modify such that Acuro is no longer necessary.
Yeah, absolutely. That was well put. Thank you. As for, I know you mentioned the medication piece. That one I'd have to reach out to my colleagues for. I think if a medication, like you were saying, antihypertensives and things, was ordered in Acuro, we would still, and my colleagues can answer this, we would still need to see it within CST Cerner, correct?
I think that would be one of those things where I would probably, my gut feeling is that would be what we would call the ideal state. Mm-hmm. The real state will be different, because I don't think there's any medical legal way you can stop me from just writing a prescription on a pad and giving it to a patient.
No, I agree. Yeah, exactly.
So we're talking about what we would like to get to, versus what we are obliged to do is the way I would put it. And that's where I worry about the path of least resistance, which for the immediate future will actually be Acuro over Cerner.
Yeah. Okay. That makes sense. Sorry, go ahead.
Oh, this might not be the best place to insert it, but just so Dr. Song and I think everyone on the call already knows, we will be differentiating between Acuro and Cerner separately within the navigator scope design, just to as an FYI.
Thank you.
Yep. Okay, so I think we're okay to move on unless anybody else has any questions or remarks about Acuro functionality. Okay, well, thank you, Dr. Song.
Thank you so much, Grace. So let's wrap up this clinic visit.
Oh, just one last thing. I was thinking, and I don't know whether this really makes any sense or whether I need to understand this a bit better, but maybe I'm asking this question because I'm trying to understand this. Mm-hmm. We do a lot of, tasking and communications through Acuro. I think Cerner has that capability as well, too. Is that correct?
Yeah, go ahead, Haley.
Yes, Cerner doesn't have not exactly the same type of tasking, but we do have a communication that can happen within Cerner, and we are using, or we're using or proposing that within the navigator design, especially. So we understand how Acuro is used for tasking within navigator's office, and we are looking to imitate and maybe even better that kind of communication with the future state workflow. So we are working with Marie and Charlie and the navigators with to make sure that that's effective in the future state.
Okay, thank you. That's I know it's not going to be exactly the same, but I think that's one of the things that in Acuro we've gotten very used to and find it very easy to use it for.
Okay, is there anything else did I miss something in regards to, I spoke directly in regards to navigators, but is there anything from doctor's clinic standpoint or something that we're missing for the tasking?
Well, from the doctor's clinic, when we see a patient, the way we communicate is we fill out the TWRF and then we task it to the navigator so that they know that we want this to be started. So since we did speak about TWRF, if I do fill it out, how do I send it to somebody so that they know what to do with it?
Right. So we are looking to see what we can do for the functionality of tasking from the TWRF standpoint, and we are covering it within navigator design. So just know that it is being covered there, and also we're including providers in that discussion also. Okay. So we will make sure that it's as seamless as possible if it is to be kind of copied into Cerner.
just from my knowledge right now, is this current state of Cerner one where we fill out the form, we have to print it out, and then we have to put it on the desk of our navigators?
No, that's, we're hoping that we have other options for sure for that. The hope is to not have it on paper.
Okay. And so maybe just going on to that and extending that a little bit further, if I do order a CT scan on Mr. Smith and I want my secretary to do it, I would fill that out and I would task her to sort out a what do you call it, the radiology, a CT scan in the next 2 weeks if possible. Right now, what would I do on Cerner if I wanted to do that?
I want to, if I can, defer that question to just the provider team. My understanding is that MI orders would go directly to the MI clerks to schedule, and you could, when sending that request, add a comment as to when to schedule it. But I'll let my team elaborate if I'm off.
No, that's correct, Haley. And what you're going to put, Kevin, is on the special instruction notes that is upfront for the scheduler, so you can say 2 weeks. Either before X or after X, or in exactly 2 weeks or around. And so that's what they have, the schedulers, and they will be able to book, and that goes directly. So if this is one of the things that you have to consider, that Acura might be handy because you will know how to use it, but this will send electronically directly to the request list that order for your patient, so it will be faster at any rate.
Okay, so I guess I'm trying to think of the pros and cons of this. One of the beauties of, or the fortunes that I have of tasking to my secretary is that once I've tasked it, I just totally forget about it and move on. Whereas when the secretary is not involved, then I have to follow up on it and I have to find out whether they're booking it and all that kind of stuff. Or I would get my secretary to, I guess, sort that out. So they would not be involved in any of the process of me getting a CT scan at my hospital, unless I ask them to.
That's correct.
Okay.
And knowing that, yeah, you will receive directly the result in the patient chart. So,
okay. Okay. Yeah. Well, maybe this is part of the future state of, in terms of efficiency as well too. So I guess we just have to learn how to be more independent and less reliant on our assistants.
Correct.
Okay. So just out of curiosity, will the imaging department here accept requisitions outside of Cerner?
Say that again. Would they accept requisitions from Acura? Yes, they will. Just like you will accept requisitions from anybody else.
Okay, so yeah, because I guess there are people external to VGH who ask for scans that to be done at the VGH as well too. So for instance, let's say a year from now, I do it the Cerner way, the way that I would want to, and everybody would prefer I do, and that's great, and it works out really well. But I have a colleague of mine who just really hates Cerner, and he decides that he's going to actually fax a requisition to medical imaging from a regular paper copy. They would still accept that, though.
I'm just going to summarize that as my GP. I want me to get a CT scan, and he doesn't have access to Cerner, so he sends a fax to VGH, and VGH will book me. They will create an encounter for me, put my information, and then find a way when to book me. Okay. So all our services will receive still faxes, and they will act over those.
Okay. All right. So one way or another, I guess many services are going to be forced to be somewhat hybrid as well too, that it's not going to be 100% Cerner, I guess. Okay. Thank you. That was very helpful.
Thank you. So let's just wrap up our clinic visit with a follow-up order for the patient if needed. So we'll place the follow-up clinic VGH BMT's doctor's clinic order. I think we I have reviewed this last time as well, so this order will look like this. You can enter modality if you want. Scheduling priority, appointment requested. So you'll see your appointment types here. Just do BMT follow-up now. Go ahead and sign. And once you're finished off with the patient, we'll go back into ambulatory organizer. And then you can click Seen by Provider. It'll also trigger automatically if you sign a clinic note. And then this lets the clerk know that the patient is done with the doctor's or provider portion of the visit. Any questions, Dr. Song?
No.
Okay, perfect. And just one last question for you. Do you envision your team needing provider, provider pools or clerical pools or pools for your entire clinic? Just not too sure if you guys have overlapping in resources, if you guys share patients, or if you need to do like team communication.
So I may not be understanding your question, but if there are communications we need, we send out an email to the respective groups. Are you saying that should we try to do it on Cerner? I think that we're doing it in email and it's fine. Maybe I'm misunderstanding your question.
So for example, if there are patients, I guess I'm speaking to the provider pool specifically.
Okay.
Within the doctor's clinic right now, if you share patients with another provider, and if you guys do overlapping, and if that's common, a provider pool might be recommended. But if you guys don't really have any overlap, then
so maybe my the question you're asking is how do we practice? We're a group practice. We have patients that are assigned to one of us, but really that patient belongs to the whole group. So the provider pool would be that all BMT physicians should be able to access each other's patients. Does that answer your question?
Yes.
We cross cover each other all the time.
Okay.
We co-sign for each other's patients. As I said, I may have a patient who says my primary doctor is Dr. Song, but when I'm away, any of my colleagues can take over. If I get hit by a car, if I go on vacation, my colleagues cannot say, I will not take care of you because you belong to Dr. Song, because the patients belong to the BMT program.
Okay, sounds good. That answers our question fully. Jack, do you have any questions for the Muscle Center pool piece for Dr. Song or the clinic?
This is Haley. I don't know if I can ask a question here about this one. So Message Center is kind of it's communication regarding a patient, and it can be utilized. So obviously within Cerner, as you kind of mentioned how it's similar to kind of an email, but when discussing patients, it's a tool and system to do that. So when we have a provider pool, it would be all providers that need to be on, within that provider pool to be seeing that communication in regards to a patient between, from maybe the clerks to all providers, saying like we have a patient that could use someone. I'm trying to think of a scenario, but we have a patient that could potentially use a quick assessment or a quick appointment because they don't have enough time today. This is the patient they called in. It's something like that, and it would go to all the providers, and then a provider could respond back to it. It's an in-system communication tool. And so, do we have? Can you think of any other groups outside of just the providers and also just the clerical pool that you would need to kind of reach out to from doctor's clinic to maybe throw that communication out there and see who can respond to it?
So I would say that a provider pool would be reasonable to have for all of us. How frequently you would use it in the setting that you have described? I don't think it would be very frequent. A clerical pool, I think I would ask the clerks about that.
Okay. I think we can definitely ask the clerk. And it's all we create the pools. Anyone can kind of adjust, like they can add themselves to the pool and they can leave the pool. And so within Message Center, it's pretty flexible. So as long as we have the pool created, providers can opt into a provider pool and leave, say if they're not maybe within the doctor's clinic. There's a lot of flexibility in that. We just need to know what pools to create. And then beyond that, anyone can jump into a clerical pool or opt out. Same with proxy. You can also, one of your colleagues can take proxy on your messages if maybe they're covering you for the day. There's a few different ways that functionality within Message Center can help with that communication. But if we say that provider pool and clerical pool are pretty much maybe the only pools that would be utilized within doctor's clinics, then that's fair.
Yeah, I think that's fair. I mean, and as to create a pool doesn't necessarily mean that you'll use it, but so might as well have it.
Okay. Yeah, exactly. We can create it, and if it's not for use, it's not a mandatory aspect of the system for sure.
Excellent. Thank you so much. Okay, so we are at time. Do we have any last words from anyone on the call from the clinics, please? If not, maybe we can wrap up and then you'll be hearing from us through email. Okay, I'll take silence as a no. Yeah. Oh, sorry. Was it Haley?
Oh, I just wanted to say thank you so much to the BMT team for your time. It's been really helpful.
Mm-hmm. We really appreciate the time that you gave us today to review anything outstanding. Yes. Okay, thank you everyone for your time. So thank you so much. Thank you.
Thank you, everyone.
Thank you.
Okay, bye for now.